Swayam Prabha. Digital India. Educated India.
I am Dr. Srividya, Professor and Head of the Department of Anatomy, Changalpat Medical College. In this series of clinical anatomy discussions, today we are going to see the club foot. At the end of this session, as first year MBBS students, you will all be able to list the types of the club foot, describe the position of the club foot, name the muscles and joints involved, resulting in the position of the foot in club foot. Describe the various angles affected between the bony points in the X-ray in club foot, the types of management available, and the complications. Now, the types of management, you may wonder as first year MBBS students, why you want. They are all related, very simple. We are just going to touch upon that just to have an overview of what is expected of you to know. So, we'll take you through a clinical case where a 20-day-old female newborn was brought to the outpatient department by her mother with the complaints that the baby's feet were not normal. The doctor, on examining the child, found that both the feet of the baby were plantar flexed and inverted. He was unable to invert or dorsiflex the foot. So, what could be the possible diagnosis? And explain the anatomical basis responsible for the clinical features seen. So, with these questions, we will go on to the discussion. So, on a brief introduction of what is club foot, it is a malformation of the foot, and it is almost always congenital in nature. So, congenital can be always either maternal factors or fetal factors. When it comes to maternal factors, the maternal obesity, maternal smoking are some of the very common things that are associated with this malformation. Sometimes when there is less licher we call it as oligohydramnios, the fluid that is present in the amniotic cavity, which is responsible for many of the functions to take care of the baby in utero, when that is less, oligohydramnios, that can also cause this malformation. There are several types present, which I'll be enumerating in a subsequent slide, but the most common is Talipes equinovarus type. It is seen 2 in 1,000 neonates are affected, and boys are affected twice more than girls. So before we go into the proper club foot, I would just like you to know about the gross anatomy of the foot. Just like your hand, it has where the carpals and metacarpals and phalanges are there. Here there is tarsals, metatarsals and phalanges. There is not much difference between the metatarsal and metacarpal except for the size and the phalanges, of course. But then, with regards to the tarsals, as against 8 carpals, here there are 7 tarsal bones. And they're all slightly bigger and positioned in a different way to ensure that the main function of the foot, which is weight bearing and walking in uneven surfaces, and all those things are taken care by the tarsal bones. So accordingly, they are placed. Of the 7 tarsal bones, the talus, which is placed over the calcaneus. So the calcaneus is shown in purple and the talus is shown in blue. These are the 2 main bones where the talocalcaneal joint or subtalar joint is present. This subtalar joint is one of the important joints in the foot that is responsible for inversion and eversion of the foot. So, when this is compromised, the inversion and eversion action is compromised. The other joints that are present in the tarsals are the transverse tarsal joint. So there are multiple joints. Here we are, these transverse tarsal joints between the calcaneum and the navicular or the cuboid, talonavicular or calcaneocuboid. The transverse tarsal joints add stability or form to the inversion and reversion action of the subtalar joint. So these are the two main joints which are present in the foot, which are responsible for the action of the foot. So with this, we will go on to the club foot. As I told you, there are many types depending on the position of the foot. Now, if you see the equinus, it is the toes are placed in the ground, which is the heel is elevated, and this is a typical position of a horse, equine. So equine means horse, so that is why this position is called as talipus equinus. As against this position, the calcaneum is placed on the foot and the toes are above the ground. This is talipus calcaneus because the calcaneum is also in the ground. Talipus cavus, where there is an exaggerated arch of the foot because of certain deformity. So this is talipus cavus. These are varus valgus deformities, where varus means the lateral border of the foot is on the ground with the medial raised and facing medially, which is the foot is facing medially. So it is varus, and the opposite is valgus. Here it is talipus calcaneovarus, and something similar. This is equinovalgus, this is plain valgus. So what you need to know is, it is the combination of this varus valgus, equinus calcaneus, that gives rise to the various types. And of all these types that are enumerated, the congenital talipus equinovarus is what is most common. CTEV is the commonest clubfoot that we talk about in today's session, and also we see in many of the neonates. So as I told, it's congenital. The congenital effect, we already saw what could be the types. I would like to stress upon the etiopathogenesis. It's mainly malpositioning. Why the malpositioning of the foot in utero? I was just talking about the oligohydramnios. That is, the Liker amni is less in quantity in the amniotic cavity. One of the main function of this Liker amni is to give a shock, function as a shock absorber, and give adequate space for the baby to grow. Now, when this fluid is reduced, the space is reduced, thereby there is compression of many structures, of which the foot is one of the first structure to be compromised in its position. So that malpositioning, constant compression malpositioning in utero, is one of the main factors that has been put forth as a hypothesis for the presence of congenital talipoequinovarus. There are many other hypotheses like neurological, vascular, where there is a vascular compromise, neurological, where there is a nerve compromise. In fact, some say that first the bony atrophy, or rather the bony deformity starts, which gives rise to the contractures, or the other way around. So whatever it is, the main hypothesis that is put forth that you as students have to remember is the congenital cause due to malpositioning of the foot in utero, and for which the main cause is oligohydramnios, that is less amniotic fluid. So it involves the subtalar joint. As I told you, the subtalar joint is formed between the talus and the calcaneus. The calcaneus, instead of being its normal position, it's slightly shifted, where the head is more towards medially, and the alignment is in such a way that the subtalar joint position is altered, and that constantly the subtalar position altering causes the subsequent deformity in the forefoot, midfoot, and the hindfoot. So the forefoot is adducted. So you see the adducted position of the forefoot, which is seen in this bony picture. The midfoot is in a cavus position mainly because of the varus. So the lateral border of the foot being on the ground makes the mid part of the foot to be in facing medially, and that increases the cavus, the arch of the foot, because of the ligaments and the fibrous tissue that is affected will further aggravate this cavus position, and together the midfoot will be in a cavus position. As regards to the hind foot, because of the contracture of certain other tendons which I'll be talking about in the subsequent slide, it is in a equinus position. That is, the toes are placed on the ground with the heel elevated. So the hind foot is in an equinus position. So the forefoot adduction, the midfoot cavus, and the hindfoot equinus. The hindfoot equinus is because of the plantar flexion, and the increased cavus and the adducted position is due to certain other muscles. Together, they give to the typical position of the congenital talipes equinovarus position. This position, as it resembles a horse hoof, that is why it is called the equinovarus. Because of this malformation of the foot, the calf, the foot, and the tibia are all small, and resultant, the child's leg itself will be shortened in one side if it is unilateral. If it is both the sides, then the shortening is visible in both legs. What are the muscles and tendons? We just saw how the bones are positioned. Now, what are the muscles and tendons affected and which results in the bones? Now, whether it is a bones being affected in malformed, resulting in the contracture of the tendons and the ligaments, or whether there is another hypothesis relating to the clubfoot, connective tissue hypothesis, where the connective tissue is affected, leading on to fibrous structures and the bony part being affected. So in that case, the contractures cause the bony deformity. So both the hypotheses can occur. Whatever be the hypothesis, the resultant is the foot, both the bones and the tendons and the ligaments are all affected. There is a tightening of the tendons and the ligaments you see in the clubfoot. The tight intrinsic muscles of the foot, along with the flexor hallucis longus and flexor digitorum longus, are mainly responsible for the exaggerated arch, that is the cavus. The tibialis posterior being affected is responsible for the forefoot being adducted and for the heel to be elevated, that is the equinus position. The equinus position is mainly also by the tendoachilles being very tight. All this tightness is because of the contracture, and the contracture of the tendons and also the associated ligaments in that region, namely the talocalcaneal ligament or the spring ligament, the talonavicular ligament or the spring ligament, the talocalcaneal ligament, the short and long plantar ligaments, all these ligaments which are there, they also go in for the tightening, fibrosis and contracture along with the muscles, resulting in the typical cavus, adductus and equinovarus position. When it comes to the imaging part, we don't do an X-ray imaging in utero, when the baby is in utero, because the X-rays are teratogenic, so we don't do as a routine. What is routinely done intrauterine is an ultrasonography. It can be detected. The baby's foot abnormality can be detected in an ultrasonogram. But then, because the interventions cannot be done, it is only to tell the mother. Postnatally, the baby's foot X-rays can be taken that is both in AP view and lateral view, where we say a decrease in the angulation between the points. So this is a normal foot where the talocalcaneal angle, if you put a line along the calcaneum long axis, and the talus long axis, the angle that is normally present is visibly decreased in a baby affected with clubfoot. Similar, that's the talocalcaneal angle. As regards to the first metatarsal angle, the angle between the talus and the first metatarsal is also, this angle is also reduced in a baby affected with clubfoot because of the malformed position of the talus and the calcaneum. So a decrease in the angle of the talocalcaneal angle and the first metatarsal angle is very much diagnostic of a clubfoot. As I told you, management, I'm not going to go in detail. This is just to indicate to you that depending on the severity of the presentation, just a serial casting, give a leg cast. Keep changing the leg cast depending on the position of the foot. So as you correct, the position will come back to normal. So you change the cast accordingly. So do a serial casting for the baby to make the position of the foot come back to its normal position. They are also offered are long leg casts and specialized shoes for the baby to ensure that the position that is changed is retained and till longer time. Now, if it is very severe and the casts do not work, then the surgeon goes for tenotomy, that is releasing the tendon. The contracted tendons have to be released. The main tendon that is usually released is the tendoachilles because that is the main cause for the equinus position and the varus position. But then the soft tissue release, the other ligaments and the tendons also may be released depending on what is involved. So, in a nutshell, what I want the first MBBS students to learn is the position of the baby can be changed back to normal depending on the severity of the presentation. A cast applied appropriately in a serial manner with a change in the position will take care as a conservative treatment with specialized shoes. If not, the surgeon has an option of releasing the contractures to help the positioning of the foot bones back to its normal position, of course, supported by the casting again. So these are just like what are the causes, you attack the cause, you get the treatment. This is what I want the MBBS students to learn. So come back to the clinical case study. A 20-day-old female newborn brought to the OPD by her mother with the complaints that the baby's feet were not normal. The doctor, on examining the child, found that both the feet of the baby were plantar flexed and inverted. Plantar flexed, what is the possible diagnosis and the anatomical basis? The plantar flexed means the heel is elevated, the foot is on the ground. Inverted means the lateral border of the foot is on the ground with the foot facing medially. So that is a varus deformity and the plantar flexion is the equinus deformity. Together, there is an adductor, the foot is also, forefoot is also adducted. So what are the cause? The possible diagnosis, as we just saw, it is congenital talipes equinovarus. The plantar flexion, what is the anatomical basis? It is mainly because of the contracture of the tendocalcaneus, with an alteration of the subtalar joint. The position between the talus and the calcaneum is altered. The varus deformity, the inversion and the adduction is again due to the contracture of the tibialis posterior. So, what I want you to learn is, to summarize, club foot is a malposition of the foot. There may be several types like talipes equinus, talipes valgus, talipes varus, talipes calcaneus. Whatever be the type, the most common is the congenital talipes equinovarus. So said because of the resemblance to the hoof of the horse. That is why it is given the name equinovarus. The forefoot is adducted. The midfoot is inverted and cavus is more prominent, and the hindfoot is plantar flexed in an equine position. So this is a typical position of the foot that you see here. Okay, so as we do a serial casting, the baby's foot comes back to its normal. It affects twice as much as the boys than the girls. And the main pathoanatomy is that the subtalar joint, the position of the talus and the calcaneus is altered, and the tibialis posterior and the tendocalcaneus are contracted, typically resulting in the deformity that is described. Ultrasonogram in utero and postnatally X-ray clinches the diagnosis. And as I said, management is usually conservative. Lot of children come back to normal with a serial cast and a specialized shoe. Severe cases may require the concerned tendon's release. So with this, we come to the end of the topic. Thank you.